Rational Wellness Podcasters. Dr. Ben Weitz here. I'm so glad you could join me today for another episode of the Rational Wellness Podcast. Each week, I'll be bringing you the latest cutting-edge information on health and nutrition. In this media-driven world, it's easy to be confused about what's true and what's not. I'll cut through the conflicting headlines to bring you clarity, to help you optimize your health and maximize your life. Please subscribe to the Rational Wellness Podcast on iTunes, Stitcher, or YouTube. None of the information in this podcast is intended to diagnose any condition, and this podcast is not intended to substitute for going to see your medical doctor and getting sound medical advice. So let's get started on your path to better health.
You think just finding its way in me on.
Welcome, Rational Wellness Podcasters. Thank you for joining us today. Our topic for today is prostate cancer and prostate health. Prostate cancer is the third most common cause of cancer death in men, after lung and colorectal cancer. Fortunately, most prostate cancer is slow growing, and most prostate cancer is treatable if discovered before it has spread. Therefore, early detection with a prostate exam and PSA testing is important. One of the scary things about a prostate cancer diagnosis, though, is that some of the side effects of the treatments for prostate cancer include impotency and incontinence. Our focus today is on the functional medicine approach to prostate cancer. I do not believe that functional medicine can substitute for conventional treatment. And I do not think that a man who has been diagnosed with an aggressive form of prostate cancer should forego surgery or radiation or chemo and simply follow an alkaline diet and take a bunch of herbs. But on the other hand, functional medicine can provide a preventative approach as well as a way to help your body tolerate the traditional forms of treatment like surgery and chemo, as well as possibly make these treatments more effective. Also, once your treatments are done, you can use a proactive functional medicine approach to decreasing the likelihood of your cancer returning. It's better than just waiting and hoping it doesn't return. Please check with your oncologist before following any of the recommendations on this podcast today. I like the gardening analogy for a functional medicine approach to cancer. If you want to grow vegetables in your yard, you have to properly prepare the soil, make sure that the ground has the proper nutrients and fertilizer, pH balance, and moisture so that the vegetables can grow and thrive. And you need to continue to provide water and light and the proper nutrients to keep your vegetables growing. With cancer, you want to do the opposite of growing vegetables. You want to make it difficult for cancer to take root and grow in your body. By following some of the principles of a healthy lifestyle and taking some targeted nutritional supplements, you can create an environment in your body that makes it more difficult for cancer to grow. Cancer likes a high glycemic environment and prefers when your immune system is weak, when there's a lot of inflammation in your body, when there's a lot of oxidative stress, when your liver is unable to prevent carcinogenic substances from the environment from building up in your body, and when your system lacks all the nutrients and exercise and rest that normally keeps your system strong. In order to help us understand a little bit more about prostate cancer and a functional medicine approach to prostate cancer, I've asked Dr. Geo Espinosa to join us today. Dr. Geo Espinosa is a renowned naturopathic doctor, and he's a recognized authority in integrative and functional urology. Dr. Geo is clinical assistant professor at NYU Langone Medical Center, Department of Urology, where he's the director of the Integrative and Functional Urology Center. He's the author of the popular prostate cancer book, Thrive, Don't Only Survive. And he has co-authored numerous books on natural medicine in urology and men's health. Dr. Geo is the Chief Medical Officer and formulator of XY Wellness and lectures internationally on the application of science-based nutritional medicine and urology. On his time off from work, he enjoys writing on his popular blog, drgeo.com, and spending time with his lovely wife, Joanna, and 3 kids. Thank you, Dr. Geo, for joining us today.
My pleasure. Thanks for having me.
So I'd like to pick your brain for a couple of questions about how a man should approach prostate cancer before we get into the functional medicine bit, if you don't mind. So
yeah, let's do it.
So great. So the first question is, when a man finds out that his PSA is elevated for the first time, let's just say he's 50 years old, he's always had a low PSA, maybe 1 or below, and now it's 4.5. And his doctor says, let's get a biopsy. What do you think he should do?
I think everyone involved in that process should, number one, pump the brakes. Let's take a couple of deep breaths here.
Okay.
You don't, when in a situation like that, an immediate biopsy is absolutely not required. What needs to happen is, it's very common for there to be an increase in PSA for several benign reasons that are unassociated with prostate cancer. So these things include things like infection of the prostate, inflammation of the prostate, having sex before the blood draw or 24 hours before the blood draw, benign hyperplasia or BPH, which is just a growth of an enlargement of the prostate. So that's number one. Number two is that in a situation like that, you also want to ask, the practitioner should ask, have there been any changes in your urinary with your urinary system, urinary frequency or getting up at night to urinate and so forth. That's important because if there is, then that jump in PSA may be a result of either a prostatitis situation, if it's accompanied with prostate pelvic pain, or an enlargement of the prostate. And then my mind would be more at ease to not recommend a biopsy right away. So let's say that the PSA has increased, just like you mentioned, but there are no symptoms, right? Okay. I would still be careful, and I would be more cautious of that. I would be more careful in monitoring that patient, but I would wait another 3 months, 2 to 3 months, and retest. Or I would retest right away because lab errors are not uncommon.
Okay, so you wait 3 months, you get another test. Let's say it's still elevated about the same level, or maybe it's gone down a little bit.
Okay, if it's gone down a little, depends what a little is. Going down is a good thing. Let me say one thing clearly. I'm not that interested in identifying every prostate cancer cell in every prostate. I'm only interested in identifying and doing a biopsy, and I don't do biopsies, by the way, but I do make suggestions sometimes in men who, in men who I fear may have a more aggressive type of prostate cancer. The way you know that before a biopsy is not 100% yet, but we've come a long way in being better able to say, hey, for this guy, I'm definitely going to have him get a biopsy because I fear that he's going to, that he may have an aggressive type, and maybe in that situation, some sort of conventional approach is important. The way you do that is by looking at that PSA. There's a couple of things that you look at. You look at PSA change within time. So you've given me some rough numbers. I would look at PSA density. You get PSA density is a calculation where you divide PSA number over volume, and if that number is higher than 0.15, it's more indicative of prostate cancer. If it's lower than 0.15, it's less indicative. It's not an end-all be-all. It shouldn't say you shouldn't make your decision just on the PSA density, but it's just another good piece of the puzzle. In addition to that, then you want to get a blood test called a 4K score test, and that roughly tells you the possibility of the patient having some level of aggressive cancer defined as Gleason 7 or higher. Okay. Again, that's not perfect either, but it's more sensitive than PSA by itself. And so then it's pretty good. So, it's a pretty good test. Another test that I kind of been working with recently is called the Epiphany test. It's similar to the 4K score, except that it doesn't use PSA at all. And it does tell you a percentage of there being aggressive cancer versus non-aggressive cancer. I'm saying that to your audience because I think they're going to hear more about this test as well, called the Epiphany test.
And what is the Epiphany test? It's a separate blood test, or what is it?
Yeah, it's a separate blood test that it looks at certain molecules that are associated with prostate cancer if the percentage is high in a man's body. So
Okay.
it's separate. 4K score uses it does use PSA and free PSA and other what's called kallikreins. So PSA, I don't want to be overly complicated, but PSA is a protein that's called a kallikrein. There's 4 different types of kallikreins. PSA is one of them, and the 4K score uses all 4 to make a calculation and to give a percentage if one has a high risk of a prostate cancer.
Okay, great.
And then if that next, so let's say all these things indicate, hey, there might be some prostate cancer there that we may want to look at.
Right.
Then the best thing to do is what's called a multi-parametric 3 Tesla MRI. Now, all these different points that I just mentioned on this type of MRI is important. Multi-parametric 3T or 3 Tesla MRI. And that's kind of a modern type of MRI that's more sensitive to cells that might be Gleason 7s or higher.
Okay. And then if they get the MRI and it shows the possibility of cancer or likelihood of cancer, then potentially they may have a more effective biopsy because they'll know where to go for the biopsy. Is that correct?
Correct. So then the final step. So understand, Dr. Weitz, right? Patients that see me and patients that see you and patients that might see some of your audience members, they're trying to avoid a biopsy, right? That's why they go into the functional medicine guy or the natural medicine guy. So they're trying to avoid it. So this is the only reason why we're going through all these steps. A regular urologist is not going to go through these steps. They see an increase, and most will say biopsy right away.
Right.
Right. Then they'll say, "Hey, time out. Hold on. I don't want to biopsy yet." And then they'll look us up, and they'll come to us. And these are the proper steps to take, and the responsible steps to take before you say, "Hey, yay or nay." I think that sometimes people in our own field sometimes say, "Oh, most people die with prostate cancer, not from it," and all these kind of things. And that's actually true. And most people die with prostate cancer, not from it. But there is about 25,000 people in the U.S. alone, and about 300,000 all over the world do die from prostate cancer each year. So it's not that it's an indolent disease. It's indolent in most cases, but how are you going to differentiate between the person that has the deadly type and the person who does not? So I think this gives us the integrative and functional medicine practitioner a unique position in properly guiding our patients that fear prostate cancer.
So the things that most determine what are the things that most determine whether it's aggressive? Is it the Gleason score and what else?
Well, it's mostly the Gleason score.
What is a Gleason score? How is that determined?
Unrelated to Jackie Gleason, and I say that because some people thought that there was actually
to the moon, Alice.
Right. It's completely unrelated, and I don't know if Jackie Gleason. I know he didn't die from prostate cancer, but I don't know that he had it or not. So, of the Gleason score is a staging marker, right? So Gleason, so typically there are two numbers that are added up to come up with a Gleason score. The Gleason numbers are a sum of, they're either, they go from a 6 to a 10. So let's say a biopsy report comes back. And by the way, you only get a Gleason score from a biopsy. Why is that important? Sometimes there are doctors out there that with their ultrasound, and mostly doctors in the alternative field, and I think they're doing an irresponsible thing where they do the ultrasound and they give it a Gleason score. You cannot get a Gleason score just from an ultrasound. The only way you get a Gleason score is by doing a biopsy and a pathologist observing the tissue under a microscope. That is the absolute only way. So that's an important point. So then you look at the two numbers that are added together. So a 6 is typically a 3 plus 3, of course, not typically always. A 7, however, can be a Gleason 3 plus 4 or a 4 plus 3. Why does that matter? In a Gleason 3 plus 4, in some instances, I still do think that's not an aggressive disease, depending on the volume, depending on how many of those are positive, et cetera. But I don't think that's that aggressive of a disease. A Gleason 4 plus 3, however, it's a little bit more aggressive than a Gleason 3 plus 4. So that's important. After Gleason 7s, they're all considered a little bit aggressive. The higher it goes up on that Gleason scale, the more aggressive the disease.
Okay. So for men who decide to get treatment, they either have an aggressive form of cancer or they just can't live with the concept of, monitoring it and
active surveillance or something like that.
Active surveillance, yeah, which is, I guess, a better thought than watchful waiting. Is it more effective to get surgery or radiation, or are they equally effective? Keeping in mind that a lot of men are not only worried about dying, but they're worried about losing their potency. And, we all know that surgery in particular has a higher risk of impotency and incontinence.
Okay, here's the deal. First and foremost, most men are candidates for what's called active surveillance. This is a very important point, meaning that they don't need any conventional approaches, but they do need to be monitored, and they will likely not die from prostate cancer. That means that if they're diagnosed with a Gleason 6 or Gleason, low volume 3 plus 4, they might be a good candidate for active surveillance. This is a crucial point because I think that we have an opportunity as functional medicine doctors to really create a microenvironment that's hostile to prostate cancer and for them to live longer. Let me say this. The number one cause of death among patients with prostate cancer after diagnosis, it's heart attacks, not prostate cancer.
Yeah.
So I don't want to ever lose. So I can't tell you the amount of times, Ben, where I have a patient in front of me with a Gleason 6 and he says, "Oh, Dr. Geo, please help me with this. I don't need to do treatment, but my goodness, give me all the supplements because I just want to, I just want to, beat this cancer." And here they have, high LDL, low HDL, metabolic syndrome, high, they're hypertensive, high blood sugar. They weigh 300 pounds. So I have to tell them, listen, man, your focus is wrong. You're going to die from a heart attack and not prostate cancer.
Right.
And while now we can make the argument that our approach, 80% of it should work with both, helping the guy not die from prostate cancer, but also metabolic syndrome and lowering the risk of heart disease. But there's a 20% nuance with supplement recommendations and even exercise recommendations that could be more targeted to one or the other. Right. So
yep.
That's a very important point that I'm making here, because we need to redirect, we need to shift the focus sometimes based on the patients and their own individualities.
And of course, a lot of times, some of the functional medicine recommendations you're going to make to help them decrease their risk for heart disease, losing weight, those are going to be beneficial for cancer prevention as well.
That's absolutely correct. Yes, about 80% of your protocol should cover a lot of things, right? Because what are we trying to do? We're trying to lower systemic inflammation. Well, that prevents, from Alzheimer's and, cognitive decline. That prevents, a bunch of things.
Yep.
So yes, again, 20%, however, for example, if your patient is only going to take 3 supplements, I'm not sure that in this particular example that I gave with the guy with metabolic syndrome and low-grade prostate cancer,
right,
he's only going to take 3 supplements for compliance. I think that my focus will be more on cardiovascular risk, unless it's like fish oils, right? Because like fish oils and vitamin D can kind of help with both a little bit. But anything else, I would focus more on reducing, helping this guy lose weight and balancing blood sugars, perhaps berberine, and help him reduce the risk of cardiovascular disease. Once he loses weight, once we have all these blood markers, balanced out, then we can say, okay, let's look at PSA and let's see what else, what we do from a holistic perspective. So I just want to make that because I see this all the time, and I think a lot of your listeners will probably see this often as well. Now, let's just say that this guy is healthy otherwise, and he has a positive. He did a biopsy. The best biopsy to do is called a fusion targeted biopsy. So most urologists are still doing what's called an ultrasound blind biopsy. And the blind biopsy is because it's an ultrasound, right? So the ultrasound, you kind of vaguely see where the prostate is, and you kind of shoot blindly at 12 different spots. If you take 100 different cores of a prostate, which no one does, but I'm just saying, that is only 1% of the whole prostate, right?
Wow.
So it would behoove the patient to undergo a targeted biopsy, which helps the suspicious lesions like light up more so that it can target that particular area. That's a better biopsy. Let me say one thing about biopsies that a lot of natural doctors and holistic doctors get asked by men. Do biopsies spread cancer? Right?
Yeah, sure. Putting a needle into a clump of cancer cells, right? Sounds like a risky proposition. Right.
So here's the story. There is number one, there's no evidence that occurs. Maybe because no one has looked at it thoroughly. Who wants to say, hey, oh yeah, let me look at this, and if it is, we're gonna kind of extinguish a multi-billion-dollar industry just by biopsies alone. So no one is kind of looking at this. Okay. In the breast cancer literature, they have shown that there is some seeding that occurs during a biopsy. So one can assume that kind of seeding can occur anywhere. It's completely theoretical. But sometimes theories are not, they're not bogus, right? Sometimes theories are, hey, this is a theory that might never be proven to be true, but might never prove to be true, but is still like cigarette smoking was fine for like 100 years before we found out that it wasn't. So it was only a theory for a long time. Okay, fine. Here's the story. The only way one can know if they have prostate cancer is from a biopsy. That's it. That's the gold standard. There's no other way. So you either do it or you don't. Do you have the psychology of seeing your PSA go up and saying, well, I may have prostate cancer, but I don't care to find out? Well, some men do and some men don't. And I'm okay with that. As long as you know that the doctor has to say, hey, the only way to find out is through a biopsy. Okay. Right. And then you need to chart that. You need to, note that in your chart that you had that conversation, because God forbid, if he does have prostate cancer, you don't want them to come after you, or at least you want to be prepared if they do.
Right. So I want to ask the testosterone question next. we know that advanced prostate.
Give me a Ben.
Oh,
I don't
let you
think I
finish.
actually
Oh, I'm
answered your
sorry.
question.
I'm sorry.
I don't think I actually answered. I give. Sometimes I digress a little bit. I go all over the place.
Oh yeah.
But
I'm sorry. Yeah, go ahead.
I'm trying to bring real life situations into this conversation.
Yeah, no, I appreciate that.
I think you asked me.
Go ahead.
Hey, what do I do? What's the
Right.
the
positive? Exactly.
Let's
What's
say
the best
the
form of
treatment.
treatment? Yep. Okay.
Right. Okay. So then I went into active surveillance. All right, we spoke about that. Here's the deal. Let's say that it's a Gleason 7 and 4 plus 3, or even a Gleason 8.
Okay.
And the MRI shows that the whole tumor is encapsulated, meaning that it hasn't spread outside the prostate. And aggressive treatment is the best approach. When I say aggressive, for the most part, there's quite a few treatments out there, but the most standard and the ones that are most popular it's surgery, which is a prostatectomy, removal of the prostate, or radiation therapy.
Right.
Here's the story.
Yep.
The one, and of course, you go to the radiation oncologist, they'll likely say, hey, no, we can take care of this. And the surgeon will say, we can take care of this. Okay. And sometimes, by the way, with radiation therapy, there's also a period of 3 months typically of hormone deprivation therapy. So they do a little hormone deprivation therapy where they castrate chemically the man, then they do the radiation. That seems to be a better approach than just radiation by itself. And when I say better approach, I mean just from a not dying from prostate cancer perspective, or at least longevity from prostate cancer. I am a functional medicine, holistic naturopathic doctor. I am interested in my patients not dying from anything. Okay. So as I give you my protocols and what I suggest, that's my bigger picture. Of course, if they have a high aggressive risk of prostate cancer, then I'm going to address that. But, most men, like I said, die from other causes. So keep that in mind as I keep going with my story here.
Okay.
Surgery is, it seems to be the best approach. Now, radiation, the problem with external beam radiation is that it radiates the whole pelvic area. There's a higher risk of bladder cancer as a result of radiation than there is, of course, from surgery. So one needs to keep that into account.
Okay.
I know that seeds are also so brachytherapy, where they implant certain seeds in the prostate.
Right.
Well, typically the seeds go along with external beam radiation. They do it together for a short period of time, and then the seeds stay inside of you forever. What happens with seeds is that within a long period of time, it kind of starts, it's constant radiation in that area. And it starts having an effect on, radiating, the bladder eventually. And so then, urinary frequency becomes an issue, and urinary problems become an issue. So surgery increases the risk of erectile dysfunction and incontinence. And actually, I don't know if you know this, but it shrinks your penis.
Huh. Interesting.
I don't know about you, Ben, but I know most men don't have they don't have, a big enough organ to start with. So, now you shrink it by, half an inch or so. That's not insignificant.
That's kind of bizarre. Okay. How does that come about?
Because during the surgery, number one, understand this: every man has an erection 3 to 5 times a day from the time they're a teenager to the time they either have surgery or they die.
Okay.
Every single day of their life, every man after the age of 13 has an erection 3 to 5 times a day or more.
Right.
Right?
Yep.
That ends after surgery. So you have less blood flow kind of exercising the organ after surgery. That's number one. Number two, the procedure itself kind of pulls back the tissue of the penis, pulls it back, and it causes shrinkage there, by just the surgical procedure by itself.
What do you mean men after prostate cancer surgery won't have erections anymore? Or they won't have them spontaneously?
They don't have them spontaneously. You have to go through some level of penile rehabilitation, whether it's the use of, these PD5 inhibitors, Cialis, Levitra, Viagra, or injections or something to get blood in there. But there's less to no blood going in there after prostatectomy.
Automatically, no matter what, even if they get the best result.
Correct.
Okay.
And the best result, by the way, means nerve-sparing technique.
Right.
Right. So,
yeah.
And we're assuming that that is the surgery.
Right.
I'm in a little bit of a bubble here in New York because every prostate surgeon that I know, including the ones here at NYU, we have a 50-block radius where there's like the top, urology prostate surgeons in the country. And so I'm in a bubble where I automatically assume, yeah, of course it's nerve-sparing technique. I mean,
right.
Everybody does that. And I have to say that's, there's a learning curve here.
Sure.
And so you definitely want a surgeon that has the most experience so that they do indeed do a nerve-sparing technique. Quickly, robotic surgery or open surgery, which one? Doesn't really matter. You want to choose the expertise and the experience of the surgeon, not the technique first.
Seems like all the top surgeons are doing a robotic surgery these days.
Correct, because of its demand. It's supply and demand, and people are demanding robotic surgery. That's why. And the company Da Vinci, which is a robotic company with the robotic equipment, they've done an excellent marketing job.
Right.
And so then everybody's asking for robotic. Now, if you do have, so then here's how you make the decision. Number one, you choose the surgeon, the surgeon's technique and experience before the technique. Number two, if the surgeon, you choose a surgeon that if he's well versed in robotic surgery, then you choose that technique, and if hoping that he's also versed in open surgeries. The reason why that's important is because with any complication of the robotic surgery, then they can go ahead and do an open surgery if needed, if there's a complication. And then third, you use just a person who is the doctor who is well versed in robotic surgery, even if they don't have experience in open surgery. Why am I saying that? Because all surgeons in this day and age, in their residence and fellowships, are being trained for robotic surgery and not open.
I see. Okay. So it's not an easy question to answer about which treatment to get.
It's not. It has to be very individualized. It has to be what's important to the patient. It has to be, the pathology of the disease and so forth. And there's HIFU, by the way, out there, high intensive frequency ultrasound, and there's marketing for that. And, it has to be more individualized. In my book, I kind of highlight the main type of treatment. I know that we don't want to take up a whole lot of our time during this conversation. I mean, this could be a 3-hour podcast very easily. In my book, Thrive, Don't Only Survive, I talk about the different types of procedures that one may be interested in or at least look into.
Okay. So let's get to the functional medicine stuff, because that's podcast is really focused on that. So why is diet important for men who want to either prevent prostate cancer or who have prostate cancer and or who've had prostate cancer and want to prevent it from coming back? And what type of diet and nutritional factors can be the most helpful? I know that's kind of a big question, but sort of a general.
Oh man, and with a talker like me, we could spend here. The rest of the, it's 3:20 here in New York, and I know.
How about this? Should I follow plant-based diet? Should I do paleo? Should I do Mediterranean?
Right, here we
what
go.
should I do?
Here we go. I got it for you. I'm gonna do my best here, Ben, to summarize.
Okay.
I'm gonna do my best. Here we go. Let's talk, first of all, before we go into what's the diet, let's talk about what's the goal. What are we trying to accomplish? What we're trying to accomplish is to create a microenvironment that's hostile to cancer cells. Okay, so how do you do that? All right, there's 5 things you need to do. You need to lower inflammation. or inflammatory markers, lipooxygenase and NF-kappa B and these kinds of things that promote cancer. You want to protect cells from oxidative stress. You want to be able to detoxify the body, right? Crap comes in, crap comes out. Not keep it in, right?
Yeah.
Number 4, you want to maintain and sustain a strong immune system,
Right.
particularly the natural killer cells. And number 5, you want to control blood sugar levels and insulin production.
Okay.
Right. So the whole recommendation, I talk in the book about the capless method. That's a program that I've developed for prostate cancer, and it's really addressing these 5 things. And that's it. So everything we do is to address these 5 things. Okay. So what does that mean from a dietary perspective? Number 1, you want to consume a lot of cruciferous vegetables. The literature making
those are broccoli, cauliflower, Brussels sprouts, cabbage, etc.
That's right. Those are the biggies. Now, is kale bad? No, kale is not bad. Is spinach bad? It's bad only if it's not organic. But if it's organic, it's good. Spinach. But the heavy hitters here are the crucifers, those that you just mentioned. Okay, so you want to eat those, till the cows come home.
Okay.
So those are.
In other words, Doc, you want me to have a lot of gas?
Perhaps.
I'm kidding.
Look, I eat a lot of those.
No, I eat those every day.
Here's the deal. I don't promote eating any of these raw. So you know how when you go to a party and there's the cheese plate and there's the vegetable plate and there's like raw cauliflower and raw broccoli and everybody's looking at you because that's Dr. Weitz. He's the health guru, so I know he's going to choose the vegetables. Oh, that's Dr. Geo. He's going to definitely. I'm like, no, I'm going to the cheese platter. First of all, I'm not going to eat the freaking raw broccoli. That will cause a lot of gas, and that's just not digestible.
Right.
Or the raw cauliflower. So I'd rather have a little bit of cheese than, mess up my gut. So the point there is that, no, it needs to be steamed. Steam lightly, however, but it needs to be steamed. Okay,
right.
Let's move. And it kind of breaks up the whole scientific process why that happened.
Right. Okay.
And why the key ingredients in those vegetables get absorbed. All right, let's move on. Should I go paleo? Should I go vegan? The hot diet of the week. What's the hot diet of this week? I don't know. Ketogenic. Yeah, that's it. Ketogenic is the hot diet.
Yeah.
All right. Here's the story. And this is specific to prostate cancer. I know that they do research for breast. And by the way, breast cancer literature is actually, and what you do for breast cancer is analogous to prostate cancer because they're very similar in how they behave. So that information is always interesting. But brain cancer and other cancers are a little bit different. Here's the story. You want a low carbohydrate diet. Ketogenic diet for prostate cancer has not been looked at. It's been looked at mostly for brain cancer. But however, I do put my patients with advanced prostate cancer in. I don't measure ketones. It's just too arduous to do it every day. But I do put them on a very low carbohydrate diet and include fat and a lot of crucifers in their diet. And they seem to do well, not only responding from a cancer perspective, but also, just feeling good, particularly after therapy, whether it's AD, hormone therapy or what have you. So that approach. So here's the best diet for prostate cancer. It's a combination of plant-based, Mediterranean, and ketogenic. Combine all these 3 with a lot of crucifers. Combine all these things, and that's actually the capless way to eat from the book. It's Mediterranean, ketogenic, plant-based, and lots of crucifers. That's how you want to eat. So that includes fish, nuts, seeds, etc.
Okay, let me ask you a specific question. When you follow that sort of regimen, a lot of times it's tricky figuring out what's a good source of protein to eat. We know that red meat seems to be associated with slightly increased risk of prostate cancer. Is that true? Outside of fish, what are the healthiest sources of protein for men with prostate cancer to eat? Should they eat chicken if it's organic? Should they have red, or should they have a grass-fed organic red meat? Is that okay? What are the best sources of protein?
All right. You don't ask easy questions, Ben, and I don't answer questions too lightly. So here we go.
Okay.
The literature says this. Forget about what you read on the internet, because people kind of exaggerate, what they read or how to interpret it. Here's what the literature says with regard to prostate cancer and meats. It doesn't say that people who eat meat are at higher risk. It says that people who eat more processed meats are at a higher risk. This is the bolognas and the salamis and, the hams and things like that. Cold cuts.
Right.
Also, it says that those that cook the meats at high temperature are at a higher risk.
Like on a barbecue.
Barbecue, or you're correct. Even grilling or broiling.
Yeah.
By the way, it's not exclusive to meat. It's also fish. So those that cook fish, even wild Alaskan salmon at high temperatures, that also increases the risk.
So basically, if it has
the preparation is as important as the type of meat.
So basically, if you get the fish and it has those black lines on it, that's a bad sign, right?
Yeah, the more black, let's be holistic but realistic here for 1 second. You go to a restaurant, sometimes there's a lot of black lines, sometimes there's not so many, depending on the restaurant you go. I wouldn't go crazy. I mean, it's like 1 or 2 lines, no problem. Particularly if you add rosemary to your meat, whether it's salmon or beef, because rosemary kind of interferes with the formation of hydrocyclic amines, which that's the burning part, those streaks and lines. Those are hydrocyclic amines. So you want rosemary in it. So I wouldn't go crazy. But sometimes you see a lot of black. You could play checkers on one of these pieces of salmon, and so you want to, you don't want that.
Right.
You don't want that. So that's the meat story in a nutshell.
Okay.
Was that satisfactory?
Yeah. No, that's good.
Yeah.
I know we could talk about this stuff forever. So, you talk about in your book, which is an excellent book, Thrive, Don't Only Survive, about how you need to try to boost your immunity, and certain specific supplements can be effective for that. Which ones do you think are most effective for boosting immunity?
My favorite are reishi mushroom.
Okay.
And 8-HCC, active hexocorrelated compound, which is another type of mushroom. Those are my top 2 favorite. Yeah, you can add astragalus and a small amount of vitamin C, etc. But if you were to ask me, hey, gun in my head, what are the top 2? I would say the top 2 are reishi mushroom and astragalus. I also like grapeseed extract, by the way. Big study, 25,000 people. They looked at all the supplements they take. They were taking salt, palmetto, fish oils, all kinds of things. Mm-hmm. And the only thing that reduced the risk of prostate cancer by 24% was grapeseed extract. Correlation still, not causation, but still it was a big study.
So would resveratrol have similar benefits, since it's, almost...
Yeah. Resveratrol seems to be a good idea. I don't, just like you, right? Benny, I mean, you have to prioritize like top tier for what your patient needs, right?
Yep.
You have your top tiers depending on what they need, right? And what they're coming in with.
Yeah.
My top tier are things like my top tier. You want me to go through that list in my head? I could do that.
Sure.
Okay, my top tier in terms of botanicals, they include curcumin, boswellia, grapeseed extract, modified citrus pectin, reishi mushroom, milk thistle, broccoli extract. I use broccoraphanin. Those are my top tier. In terms of nutrients, it includes selenium, specifically from selenized yeast. I don't use selenomethionine for any of my prostate cancer patients. I think that's an important point.
Why is that?
I was waiting for the why. Because because selenium. So you have to be careful with isolating antioxidants. I think once you start isolating anything, so sometimes you go to the internet, you say, "Oh, antioxidants can cause cancer." Well, that's not totally false. It primarily causes cancer if it's just an isolating, like DL alpha tocopherol, for example, vitamin E. Well,
Right.
that is carcinogenic, as opposed to mixed tocopherols that include
Right.
high levels of gamma tocopherol, which is
Right.
exactly what I use. I use high gamma.
Right.
Selenized yeast, number one, there was a JAMA study from 1996 showing there was a 63% reduction of prostate cancer in people that used this type of selenium. And it's a mixture of, it does have selenomethionine, but it has two other types of selenium. Selenocysteine and selenomethylcysteine and So the whole seems to work better than the sum of its parts.
Okay.
And in another study, comparing selenomethionine to selenized yeast, showed that there was a better, more antioxidant capacity in the formula of selenized yeast compared to selenomethionine. So that's the kind of selenium you want to use. You want to use selenized yeast. Seleno Excel is the name of the type that I use.
Okay.
So then I use a little alpha lipoic acid, vitamin C, about 1,000 to 2,000 a day. So people talk about, hey, how about IV vitamin C therapy? That's fine. I don't do it. And there's very little literature with regards to that. There's more literature with kidney cancer and ovarian cancer, but I think it's perfectly fine if that's what a patient wants to do, or if the doctor thinks that's the right thing to do. IV vitamin C therapy at high dosages, no problem. And I use zinc as well. And so that's those are the supplements that I use in addition to following the capless eating regimen.
Hey, can we put a couple of myths to bed real quick here?
Let's do it.
Isn't it the case that fish oil and vitamin E do not increase your risk of prostate cancer? And we probably throw in calcium.
The two busiest times of my entire career of 15 years, the two busiest times were when this bogus freaking study published by a Journal of Cancer Institute, which I was so surprised because it was such a bad study.
Right, the fish oil one.
Fish oils increases the risk of prostate cancer. And then, of course, it's the SELECT trial, which never dies. There's a 20-year-old trial that closed, and it never dies. It keeps popping its ugly head with vitamin E and prostate cancer.
Right.
So irritating. And the reason why it's irritating, because then, of course, people they stop taking these two vitamins, which are so protective for so many things that they're doing a disservice to themselves. Long story short, the study that was published maybe 3 years ago by Brasky, I don't even know the darn guy's name. They looked at old blood levels of people, which, by the way, you cannot measure fish oils that way and the fatty acids that way, particularly with prostate cancer, and made a correlation. Hey, those at higher levels of these fatty acids had higher levels of prostate cancer. Well, that's not, number one, you cannot look at it that way. That's why I'm not pissed off at Brasky. I'm upset at the journal that accepted this. I write articles, like review our scientific articles, and I get turned down pretty often because the rigor is not, good enough. And I say, okay, well, we'll keep working on it. I'm very surprised that the Journal of Cancer Institute accepted that paper. Forget about what I have to say, because many people say, hey, of course you'll say that. You're a natural doctor. The most conservative, conventional doctors out there have been quoted and interviewed saying that is such a bogus study, flawed in design. I can't believe it was even published. So I want to tell the audience to not stop taking in fish oils. And number one, particularly in men with prostate cancer, it does a whole lot more good than harm. I wrote about it extensively with a lot of citations on drgeo.com, my blog. That anybody who's interested can look that up. And that's Geo with an E.
Great.
Vitamin E, SELECT trial, same the select trial really shows that DL alpha tocopherol, which is synthetic form of vitamin E, it's a problem and can increase the risk of prostate cancer. But who in their right mind are taking it? Is it out there, or is DL alpha tocopherol, particularly at very high dosages, sold out there? Yes, it's still out there. A patient brought me a bottle and it said very clear, 400 units of DL alpha tocopherol. Of course, in our space, we don't deal with DL alpha tocopherol, but we got to keep in mind that people are going to go out there and go to a CVS or something and get their, get their vitamins. So, you pay for what you get for sometimes.
Absolutely. Thank you for helping to put those to bed. I've been screaming about those too. That fish oil study was so bogus. And the conclusion, though, in the study was that taking fish oil supplements increased your risk of prostate cancer. And none of the men in the study were taking fish oil supplements. So anyway.
That's right. That's right. And it also suggested, hey, not only that omega-3s increase the risk, but actually those that have higher levels of omega-6s in their blood had a lower risk. Oh, really? All right,
exactly.
Everybody start eating your corn oil and
stop eating and stop eating fish. That would be the conclusion of that.
Don't eat fish, eat vegetable oil.
Yeah,
and that's how that's how you're going to lower your risk.
Right.
Unbelievable. I really, literally, my blood pressure goes up by 20 points every time I talk about this crap. Because I can't believe that was even published.
Right. I completely agree. And finally, the calcium story was put to bed because recently there was a study that showed that taking calcium did not increase your risk of prostate cancer.
Not only that, what happens is, vitamin D and calcium works together. So those with very low or deficient in vitamin E with more calcium, then that ratio is a problem. I think it's not a matter of the calcium, it's a matter of people having proper levels of vitamin D in their blood. And can I say something about vitamin E? And that's it. I won't say anything else. I promise. We'll cut it. Vitamin D. Here's the story. People in our circle, Ben,
yes.
We get patients to take, hey, we want level higher is better. We want levels in 80, blood levels at 80 or 90. Ben, I looked at the literature very closely, and it doesn't say that. In fact, there's a U-shaped J curve on the literature that I've seen, both with men and women, indicating, yeah, of course, if you have extreme low levels under 30, you're at a higher risk of prostate cancer. But higher than 40, 45 doesn't make things better. In fact, there's more mortality in higher than 45 as well. So, and the reason why I'm saying this is because, every now and then, of course, you cannot do search through the literature on everything. And you go to the conferences and you say, hey, that makes sense. I'm going to apply it. Every now and then I say, all right, let me dig in and see what's really going on. And that's my finding. I looked at every good study, big numbers and so forth. And I don't have my patients at higher levels than 40 to 45. And I don't know where these numbers of 80 to 90 come about. But I haven't seen, other than just people saying that, I haven't seen that in the literature, not even in the Vitamin D Council website. So
interesting. I just did a survey of functional medicine practitioners, and overwhelmingly the view was the optimal level was between 50 and 70.
Correct. And I'm surprised that it's not 80 or 90. Like I see some other, holistic practitioners talk about.
But you're saying the optimal level is what, 30 to 45? Is that what you feel?
No, hovering around 40.
So
40, 45. That is the optimal level. Now, if anyone listening can
30 to
share
50.
with me any type, I hover around 40, 45.
Wow.
30, I think it might be too low. And by the way, every unit is apparently meaningful. It's the same thing. Hey, Ben, let's go run 3 miles. And we're not real runners. All right, let's do an extra 1 mile. Oh, that sounds like nothing, but that's a significant amount if you're not a runner. So in this case, every 1 unit is a big deal. So I hover around 40. That's what I've seen. Now, I haven't seen anything saying, hey, around 50 to 70 is optimal. I just haven't seen it.
That's great. Well, Dr. Geo, I appreciate your time. I would love to keep this conversation going, but I know that you have things to do and I have things to do. So let's continue this conversation sometime in the future. For patients and practitioners who are listening to this podcast who'd like to get in touch with you, what's the best way for them to get in touch with you?
Oh, thank you very much. I think the best way is drgeo.com. That's Geo with an E. People joke and they say, oh, that's E for erections. Okay, fine. drgeo.com with an E.
That's great. Thank you so much for joining us, Dr. Geo. And I'll talk to you soon.
My pleasure.
Okay, thank you.
Be well. Bye-bye.